Welcome back to the deep dive. Today we're diving into, well, one of the most devastating injuries we see in orthopedic trauma, scapulothoracic dissociation, or STD. It's notoriously difficult to spot, especially in complex polytrauma cases, and the stakes are incredibly high.
They really are. It's a rare injury, thankfully, but when you do encounter it, it changes everything in the trauma bay. We're talking about a massive high-energy disruption, a complete tearing away, effectively, of the shoulder girdle from the body. It's often described quite grimly as a ERM, a closed traumatic four-quarter amputation. The skin's intact, but underneath, the detachment is catastrophic.
And those high stakes you mentioned, for our colleagues listening, particularly those in major trauma units, the numbers themselves are quite chilling, aren't they? Can you give us a sense of that initial challenge?
Yes, straight away, you're dealing with a dual threat. There's the immediate risk to life. Acute mortality, often because of the associated chest and vascular injuries, sits consistently around 10 to 11% in most published series. That's significant.
And for those who survived that initial hit,
Well, that's where the second challenge comes in the functional prognosis. It's often incredibly poor. We see amputation being necessary in, well, up to 20% of patients. And perhaps the biggest long-term problem is the development of a flail extremity, a completely non-functional arm, basically. That happens in up to actually just over half the patients in some cohorts, around 52%.
those figures are stark. They really underscore why we need this deep dive. So our mission today is really to unpack this, to look at why it gets missed, explore the controversies around treatment, especially arterial repair, and crucially, identify what truly predicts the outcome. Because as I understand it, for orthopedic professionals, the long-term function seems to hinge almost entirely on the nerve damage, doesn't it?
That's exactly right. The neurological injury is the absolute key. That's where we need to focus our scrutiny.
Okay, let's start at the beginning then. The mechanism. This isn't just a fall onto the shoulder, is it? The energy involved sounds immense.
Oh, absolutely. The mechanism is almost pathognomonic, you could say. You're looking for extreme high-velocity forces. Typically, it's a severe lateral traction injury to the whole shoulder girdle. Imagine perhaps a motorcyclist coming off their bike and being dragged by the arm, or a very heavy object crushing the shoulder sideways, pulling it away from the body.
So a tearing force, essentially.
Precisely. It's that sheer force pulling the scapula complex laterally, away from the rib cage. It overwhelms everything, the muscles like the trapezius, rhomboids, levator scapulae, but also the key joints, the AC and SC joints. It tears the whole anchor point off the torso.
And given that kind of force, these patients are rarely coming in with just an isolated shoulder problem. It's usually part of a much bigger picture.
Almost always. Polytrauma is the rule, definitely not the exception. If you look at the injury severity scores, the ISS, they're consistently high. Cohorts often report average scores around 22. That tells you these patients have multiple serious injuries.
What kind of orthopedic injuries do we typically see alongside the dissociation itself?
Well, you frequently find widely displaced clavicle fractures, often mid-shaft or distal end. Scapula fractures are common too, the body, the spine, sometimes the neck, and crucially, you often see simultaneous disruption of both the acromioclavicular joint, the AC joint, and the sternoclavicular joint, the SC joint. The whole ring is broken.
But the immediate life-threatening issues often aren't the bones, are they?
No, exactly. The really acute threat tends to come from the non-orthopedic injuries. Because of the sheer violence transferred to the chest, you see significant lung trauma, pneumothorax, hemothorax. The chest wall itself might be damaged, leading to a flail chest. And there's the proximity to the heart and major vessels in the mediastinum. It's usually these associated injuries that cause the profound hemodynamic instability and, sadly, contribute to that early mortality rate we mentioned. You're fundamentally saving a life first.
Right, and that creates a real diagnostic challenge, doesn't it? Trying to spot the specific, perhaps more subtle, musculoskeletal injury amidst all that chaos. Is that why it gets missed?
That's a huge part of it. In the primary and secondary surveys, the focus is rightly on immediate life threats, airway, breathing, circulation, major hemorrhage. An SCD might just present initially as massive shoulder swelling or maybe a deformity hidden by swelling and dressings. Unless you have a very high index of suspicion, it can easily be overlooked, especially if the limb still has a pulse initially.
So what clinical signs, maybe even subtle ones, should make an orthopedic surgeon or registrar think, could this be STD during that secondary survey?
You absolutely have to maintain that high index of suspicion with these high-energy mechanisms we talked about. Look beyond the obvious long bone fractures that might be distracting. Any sign of really severe soft tissue swelling around the shoulder girdle and chest wall, massive bruising, or ecchymosis spreading out. And critically, Any suggestion at all of neurovascular compromise in the hand or forearm? Check that radial pulse carefully. Is it diminished? Is it absent? Is the limb cool, pale?
So a detailed neurovascular exam of the limb is crucial even if the patient is intubated.
Absolutely essential. If the limb just seems to be hanging lifelessly or there's profound weakness that you can assess, even grossly, then STD has to be high on your differential until you've actively excluded it. Don't assume it's just a nerve palsy from a fracture.
Okay, let's move to imaging then. How do we confirm the suspicion? You mentioned the classic sign is lateral displacement of the scapula. How do we actually measure that reliably, especially on potentially poor quality initial films?
Quantification is key here, and the tool for that is the scapula index, sometimes called the Kell-Bell ratio. You typically measure this on the initial AP chest X-ray, which is often the first film available in trauma. You measure the distance from the medial border of the injured scapula to the line of the thoracic spinous processes. Then you do the same measurement on the uninjured side. The scapula index is simply the ratio of the injured side distance divided by the uninjured side distance.
And what sort of ratio are we looking for? I know there's been a bit of discussion in the literature about the exact threshold.
Yes, there has. The original work by Kell-Bell and colleagues suggested a ratio of 1.5 or greater was indicative of STD. So a 50% increase in that lateral displacement, that's pretty dramatic.
But later studies suggested a lower threshold.
That's right. Particularly the important work by Zell and his group, looking at a larger cohort of confirmed STD patients, they found that the average scapula index in their group was actually 1.29. So the current thinking, and what I'd advise clinicians, is that if you calculate a ratio of 1.29 or more, you should treat that as highly suggestive, if not definitive, for a significant scapulothoracic disruption.
So even a roughly 30% increase in displacement is a major red flag.
Absolutely. It reflects that even with slightly less traumatic displacement on the X-ray, the underlying soft tissue damage the torn muscles, the disrupted AC and SE joints, can still be catastrophic. It's a measurable sign that warrants immediate further investigation, particularly for vascular and nerve injury.
So the AP chest film flags the possibility with the index. What imaging comes next for proper characterization and planning?
The AP chest is really just the screening tool. It's often not good enough quality for detailed assessment. You'll want dedicated shoulder views, of course. But really, a CT scan is mandatory. The CT gives you the detailed bony picture. You can properly see the extent of any scapula fractures, glenoid involvement, complex clavicle fractures, and you can quantify the asymmetry much more accurately than on a plain film.
And what about the vessels, given the mechanism?
Critical point. Given the extremely high association with major vascular injury, usually the subclavian artery, sometimes the axillary artery, the CT angiography, CTA, is essentially non-negotiable in suspected STD, or, depending on resources and stability, formal angiography.
Why is the vascular risk so high?
Just think about the anatomy. The subclavian artery runs right under the clavicle and the SC joint. When those structures are violently torn apart and shifted laterally, that artery is put under massive stretch, or it can be directly torn or transected.
So a pulseless limb demands an immediate CTA.
Without question, the CTA will tell you if there's an occlusion, a transection, or maybe just spasm. It's absolutely crucial information to guide whether the patient needs emergent vascular surgery or if perhaps conservative management might be an option, which we can talk more about.
Right, let's move into section 2, which tackles what you called the defining paradox of STD. In the immediate aftermath, the focus is often on the vascular injury, saving the limb, saving the life. But once the dust settles, the long-term picture seems dominated by the nerve injury. How do we navigate that tension?
It's incredibly difficult, and it defines the management challenge. You have to think sequentially. ATLS principles first. Stabilize the patient, stop the bleeding. That's paramount. Then you assess limb viability. Is there blood flow? Is the limb salvageable from an ischemic perspective? But almost concurrently, you have to be thinking about the functional salvageability. Because as you said, the neurological injury is overwhelmingly the key determinant of whether that limb, even if kept alive, will ever be useful to the patient.
Let's really drill down into that neurological picture then. You mentioned prevalence is high, but what's actually happening to the brachial plexus?
The numbers are staggering. Neurologic injury occurs in up to 90, even 95% of STD cases reported in the literature. It's almost ubiquitous with the injury. And the mechanism, that violent traction, often causes the most severe type of nerve damage possible. A complete ipsilateral brachial plexus injury. Frequently, this involves actual avulsion of the nerve roots right from the spinal cord itself.
And that's the worst case scenario from a recovery perspective.
Absolutely. Root avulsion, particularly preganglionic avulsion, where the tear is proximal to the dorsal root ganglion, means there's no connection left to the spinal cord for nerve signals to travel. These nerves simply cannot regenerate functionally. The prognosis for any meaningful motor or sensory recovery in the limb is essentially zero.
This understanding about the totality and the level of the nerve injury led to a really important shift in how we classify STD severity, didn't it? Moving beyond just listing the injured structures. Can you tell us about the Zell classification?
Yes, this was a crucial development. Earlier classification systems, like the one proposed by Damshin, tried to categorize STB based on combinations of injuries, musculoskeletal, vascular, neurological. Type 3 in that system was the classic triad of all three.
But that didn't predict outcome well.
Exactly. Follow-up studies showed that simply having all three types of injury didn't reliably tell you how the patient would do long-term. You could have a successful outcome on paper, artery repaired, fracture fixed, but the patient still had a completely useless flail limb.
So how did Zell change the focus?
Zell and his colleagues in their 2004 paper really honed in on the neurological status. They argued, very convincingly based on their data, that the single most critical factor dictating the long-term functional outcome was the nature of the nerve injury. They proposed modifying previous classifications and specifically designated the presence of a complete brachial plexus avulsion as Zell type 4. This classification forces the clinical team to confront the functional likelihood early on, not just the structural damage. They showed that while other types involving nerve injury are severe, it's the completeness of the avulsion, the irreparable nature, that truly predicts a dismal functional future.
That's such a critical distinction for clinicians managing these patients. Let's look at the evidence behind it. What did the Zell study actually find when they compared the outcomes of type 4 patients versus those with less severe or no nerve injury?
The data was pretty unequivocal, and the differences were stark. They looked at long-term functional outcomes using standard validated scores. Using the short form 36, the SF-36, which measures general physical and mental health, the type 4 patients, those with complete avulsions, scored significantly lower on both the physical and mental components compared to those with no or incomplete nerve injuries. This reflects a huge impact on their overall quality of life.
And what about shoulder-specific function?
That was even more striking. They used the subjective shoulder rating system. The average score for patients with a complete brachial plexus avulsion, the Zell type 4 group, was just 33.8 points.
33 points. That sounds incredibly low on a typical shoulder score scale.
It is devastatingly low.
Yeah.
Now, compare that to the patients in their study who had either no nerve injury or only an incomplete avulsion. Their average score was 72.5 points.
Wow, that's a difference of nearly 40 points.
Exactly. It's not just statistically significant, it's clinically profound. It represents the massive gulf between having some useful function in the limb versus having something that's effectively a hindrance.
Let's try and translate that score, 33.8, into what it means for the patient day to day. You mentioned the term flail limb. Can you describe what that actually entails for someone living with it?
A flail limb resulting from a complete brachial plexus avulsion is a really challenging condition, both physically and psychologically. It means there's a total loss of voluntary motor control. The arm hangs completely limp. There's also a complete loss of sensation, touch, pain, temperature.
So the risks of injury must be high?
Extremely high. Because the limb is insensate, patients can easily burn themselves, cut themselves, sustain pressure sores, and not even realize it until there's significant damage or infection. Beyond that, it's literally dead weight. This constant dragging on the shoulder joint can lead to chronic pain, subluxation, and discomfort. The nerve injury itself can also cause severe neuropathic pain.
And functionally, that low score suggests major impairment.
Yes, functionally. A score around 30 means severe difficulty with almost all activities of daily living involving that arm. Basic things like washing, dressing, feeding oneself become incredibly hard or impossible with that limb. It can affect balance, gait, and often just gets in the way. Patients sometimes describe it as something alien attached to them, something they have to constantly manage and protect rather than a part of themselves. It's a huge burden.
Okay, so the neurology is paramount. But here's something interesting you touched on, relating back to the initial diagnosis. We use the scapula index, the degree of displacement, to flag the injury. Did the Zell study find that the amount of initial displacement actually correlated with that final dismal functional outcome in the type 4 patients?
That was one of the really fascinating and perhaps counterintuitive findings of their study. They specifically looked for a correlation between the initial scapula index, that measure of how far the scapula was displaced, and the final functional outcome scores, like the SF-36 and the subjective shoulder rating. And they found no statistically significant correlation. The p-value was greater than 0.05.
That seems surprising. You'd intuitively think a bigger displacement must mean a worse injury overall and therefore a worse outcome.
You would, wouldn't you?
Mm.
But what this finding really highlights is the disconnect between the skeletal injury and the neurological injury. The degree of displacement tells you about the energy of the trauma, the severity of the mechanism that tore the soft tissues and potentially the bones. But it doesn't reliably predict the extent of the stretch or avulsion injury to the brachial plexus itself.
So you could have a relatively moderate displacement, maybe just meeting the 1.29 threshold, but still suffer a complete root avulsion.
Precisely. Or conversely, you could have a massive displacement, a ratio of 1.8 or something, but perhaps the nerve injury is incomplete, allowing for some recovery potential. The critical takeaway for orthopedic surgeons is this. Don't be falsely reassured or overly pessimistic based solely on the initial X-ray displacement. You can achieve a perfect anatomical reduction. Bring that scapula index back to 1.0. But if the nerve roots were avulsed at the time of injury, the functional outcome is still predetermined by that neurological damage.
It really forces a shift in prognostic thinking, doesn't it? Away from the bone, squarely onto the nerves.
Absolutely. Once STD is diagnosed, the primary prognostic question must be, what is the status of the brachial plexus?
Yeah.
Everything else follows from that.
Okay, let's shift gears back to the acute management in the operating theater. We're following ATLS, save life, then save limb. In STD, that often means confronting a major arterial injury, typically the subclavian or axillary artery. How urgent is the need for vascular repair?
It depends on the clinical picture, but the urgency can be absolute. If the patient is actively hemorrhaging and unstable, or if the limb is clearly ischemic, pulseless, cold, mottled, maybe developing rigor, then emergent vascular exploration and repair is non-negotiable. Life or limb is immediately threatened.
And how is that access typically?
Access can be challenging. It often requires extensive exposure, perhaps a high lateral thoracotomy, sometimes extending into the neck, or even a median sternotomy if the injury is very proximal, close to the aorta. The vascular surgeons need wide control. But this brings us right into that major controversy surrounding STD management. The question of revascularization itself.
Right. Given what we've just discussed about the dismal neurological prognosis in many cases, particularly Zell type 4, is restoring blood flow always the right thing to do for a limb that might ultimately be flail?
That's the ethical and clinical dilemma.
Yeah.
And it's not a new one. You mentioned the work by Sampson and colleagues back in 1993 that was a really pivotal paper that made people question the automatic reflex to revascularize.
What did their review find that still influences practice today?
They looked back at 11 cases of subclavian or brachial artery occlusion associated with STD. Their findings were quite stark and sobering. Of the 5 limbs where they decided not to revascularize, usually because the nerve injury was deemed complete, but there seemed to be enough collateral blood flow to keep the limb alive, all 5 limbs remained viable. They didn't become gangrenous.
And the ones they did repair?
That was the crucial part. Of the 6 limbs that did undergo successful revascularization, none of them regained any significant neurological function long-term. So the conclusion they drew, which still resonates, was that a conservative policy towards revascularization might be justified in cases with confirmed or highly suspected complete brachial plexus injury, provided the limb appears viable from collateral flow.
Why put the patient through a major vascular repair if the end result is still a functionless limb?
Exactly. You avoid the risks of major surgery, anesthesia time, blood loss, potential graft infection or thrombosis for potentially limited functional gain. So if there's no active bleeding, the limb isn't acutely ischemic, meaning there's enough collateral circulation keeping the tissues alive, and the neurological prognosis looks bleak, the decision might be made not to perform a formal arterial repair.
That's a really complex call for the trauma team, involving the vascular and orthopedic surgeons. What signs indicate adequate collateral flow in this scenario? How do you judge if the limb will survive without main vessel repair?
It requires very careful clinical assessment and monitoring, usually led by the vascular team. You're looking for a combination of signs. Capillary refill time in the fingers. Is it acceptable, say, less than 2 seconds? Skin temperature, is a limb cool but not stone cold? Skin color, is it pinkish or pale or becoming mottled? Crucially, you need to use a handheld Doppler. Even if the radial pulse is absent, can you find Doppler signals in the arteries at the wrist or in the digital decils? Audible signals are a good sign of some perfusion.
And imaging.
CTA is still vital here. It might show the main vessel occlusion, but also demonstrate a network of collateral vessels that appear to be filling the distal circulation. If the clinical signs in Doppler suggest viability, even without a palpable pulse, and especially if the neurological injury is clearly devastating, then non-operative management of the vascular injury might be deemed appropriate.
Are there risks to revascularizing a limb that's been ischemic for some time, even if technically possible?
Yes, significant risks. If a limb has been severely crushed or ischemic for hours, which can happen with delayed presentation or diagnosis of STD, restoring flow can trigger massive reperfusion injury. This can lead to severe compartment syndrome, requiring extensive fasciotomies, and also systemic problems like rhabdomyolysis, muscle breakdown, releasing myoglobin, which can cause acute kidney injury.
Yeah.
So, paradoxically, not revascularizing might sometimes be safer for the patient's overall physiology.
Okay, so let's assume the patient is stabilized and the vascular situation is managed either by repair or conservatively. Now the orthopedic team needs to address the musculoskeletal damage. What's the thinking on timing for ORIFF, and what are the main goals, especially if we know the functional prognosis might be poor?
The timing really depends on the patient's overall stability and the vascular plan. Ideally, orthopedic fixation happens after any vascular repair is completed and secure to avoid disrupting the graft. If conservative vascular management is chosen, then fixation can proceed once the patient is stable enough for another anesthetic. The goals of orthopedic stabilization in STD are a bit different from typical fracture fixation, where function is the main aim. Here, the primary goals are twofold. Firstly, structural protection. We need to stabilize the shoulder girdle, the clavicle, the scapula, the SC and AC joints to prevent any movement or traction forces on those delicate repaired vessels, or indeed on any remaining intact nerve fibers. An unstable mobile clavicle fragment near fresh subclavian graft is a disaster waiting to happen.
Makes sense. And the second goal?
The second goal is to create a stable musculoskeletal platform. Even if the arm is flail, an unstable, painful shoulder girdle is a significant problem. Stabilization helps manage pain, allows for easier patient handling and nursing care, prevents late deformity or non-union, and provides a stable base. This could be important later, perhaps for managing the comfort of the flail limb, or even potentially for prosthetic fitting if amputation is eventually chosen. It creates a solid foundation, regardless of the limb's function.
Right, that leads nicely into the next section. Let's really get into the orthopedic strategy. The core question many might ask is, why go through complex, potentially risky ORIF and soft tissue reconstructions if the limb is likely destined to be, as you described, Zell type 4, functionally non-salvageable? What's the deeper rationale?
It's a very valid question, and the rationale shifts focus. We're not aiming for functional recovery of the limb through the fixation itself. The nerves dictate that. We're aiming for structural integrity and pain prevention and stability. An unstable shoulder girdle, even without a functioning arm attached, can be a source of chronic pain and mechanical problems. Think about it. The scapula normally glides on the chest wall, controlled by muscles.
But in a type 4 injury, those muscles are paralyzed.
Exactly. Muscles like the trapezius, rhomboids, serratus anterior, they're all knocked out. Suddenly, the entire weight and resting tension of the shoulder complex is hanging off the ligaments, particularly the SC joint, which is the only bony link to the skeleton. If you don't stabilize the bones, clavicle, scapula, and reconstruct the key ligamentous connections, like the coracocclavicular ligaments in the SC joint capsule, the whole thing will just sag and potentially migrate. This can cause impingement, sing problems, and significant discomfort, completely separate from the flail arm itself.
So the ORIF is essentially acting as a substitute for the lost dynamic muscular support, providing static stability.
That's a perfect way to put it. The surgical construct provides the static stability that the paralyzed muscles can no longer offer. It does three key things. Protects the neurovascular structures we talked about, prevents the complications of non-union or malunion, which would make managing the limb or potential future surgery harder, and provides that crucial stability against gravity and movement.
Okay, let's talk specifics then. Can you walk us through the kind of techniques used, perhaps referencing the complex Zell-type 4 case example where maximum stability was needed? How do you approach fixing this floating shoulder girdle step by step?
Well, the overarching principle is often to fix the ring. You need to address the clavicle, the AC joint, the SE joint, and the scapula's connection to the clavicle, the CC ligaments. Often the clavicle itself needs addressing first, especially fractured, because it acts as that anterior strut protecting the underlying vessels. In the complex case, we often refer to as L-type 4 with a clavicle fracture, SE joint dislocation, and CC ligament disruption. The clavicle was stabilized early, typically around day 3, once the vascular situation was definitively stable.
What kind of fixation for the clavicle?
Usually it involves anatomical reduction and fixation with a plate. A common choice is a pre-contoured 3.5 millimeter LCP, locking compression plate. Importantly, the plate often needs to address the associated joint instability too. If it's a distal fracture or AC joint disruption, you might use something like an oblique T-plate or a hook plate that spans the AC joint to secure it to the acromion. The aim is rigid, immediate stability strong enough to counteract the weight of the flail limb and protect anything repaired underneath.
So clavicle first. Then what about reconnecting the scapula to that stabilized clavicle? The CC ligaments must be torn in a complete dissociation.
Absolutely. The core cocclavicular ligaments are always disrupted in a true STD. Reconstructing this link is vital for preventing the scapula from just dropping inferiorly. Modern techniques are very effective here. We often use a suture button device systems like the tightrope are common examples. These pass strong sutures between the coracoid process on the scapula and the clavicle, effectively recreating that ligamentous tether. This restores the vertical stability, holding the scapula up in a more anatomical position relative to the clavicle and the thorax.
Right. Now for arguably the trickiest part, the sternoclavicular joint, the SCJ. You described it as the only true bony link. Why does this joint need such beefed-up fixation, especially in a Zell-type 4 patient thinking about things like mesh plates and internal bracing?
The SCJ is always under significant stress, even in normal function. But in a Zell-type 4 injury, as we discussed, all the dynamic muscular support around the shoulder girdle is gone. The SCJ suddenly becomes the sole anchor point resisting medial collapse or posterior displacement of the entire arm and shoulder complex. Standard techniques for SCJ dislocation, like simple reduction and maybe capsular repair or figure-of-8 sutures, often aren't strong enough to withstand the long-term static load imposed by the weight of the flail limb and gravity, especially without muscle counterforce. The failure rate would likely be high.
So you need serious augmentation.
Exactly. In these highly unstable situations, like the Zell-type 4 cases requiring maximal stability, surgeons often employ a belt and braces approach. First, you achieve an anatomical reduction of the SCJ. Then you might augment the soft tissue repair with something like a dual internal brace construct. This involves placing strong suture anchors in the sternum and medial clavicle and running heavy, non-absorbable tape, like fiber tape, across the joint, mimicking ligaments.
And sometimes even a plate on top of that.
Yes, particularly when you anticipate massive long-term stress due to the complete lack of muscle function. Adding a plate, like a contoured VA LCP mesh plate that bridges the SCJ, provides another layer of robust, rigid fixation. It's secured to the medial clavicle and the sternum. This multimodal fixation, the internal bracing plus the plate, provides maximal resistance to the shearing and rotational forces that are trying to redislocate the joint. It's needed precisely because the normal dynamic checks and balances are absent.
That sounds like very complex surgery in a very difficult anatomical area. We're right next to major variables, the airway. How do surgeons ensure safety when drilling and placing hardware around the SC joint?
Meticulous preoperative planning is absolutely non-negotiable. It's a high-risk area, no question. Before even stepping into theater, you need high-resolution CT scans. The surgeon must carefully measure the bone thickness of the medial clavicle and, crucially, the manubrium or sternal body where anchors or screws will be placed. You need to know precisely how much bone depth you have to work with.
So you measure it on the CT?
Yes. You measure the thickness on axial and sagittal cuts. Let's say the sternum is 25 millimeters thick at the planned anchor site. You then select an anchor or drill depth that gives you a safe margin. Maybe you wouldn't drill deeper than 20 millimeters, leaving 5 millimeters of bone intact posteriorly. You might also use fluoroscopy intraoperatively for guidance. But the pre-op CT measurement is key to choosing the right implant lengths and trajectories to avoid catastrophic penetration into the mediastinum and injury to the great vessels or trachea. It removes the guesswork.
So the patient has survived the initial trauma, the vascular issues are addressed, the orthopedic team has achieved stable fixation. Now the focus shifts entirely to that long-term neurological picture. How long does it typically take to get a definitive answer on the nerve status, and why can't we just rely on the initial clinical exam?
The initial clinical exam testing motor function and sensation right after the injury, or as soon as the patient can cooperate, gives you a very strong indication, especially if it's a completely flail and insensate limb. That points heavily towards a severe injury like an avulsion. But for definitive confirmation and prognostication, particularly to differentiate between a complete avulsion, no hope of recovery, and perhaps a very severe stretch injury, neuromesis, where some recovery might be possible, albeit poor, we rely on electrodiagnostic studies.
EMG and nerve conduction studies.
Exactly. Electromyography, EMG, looks for electrical activity in the muscles.
Yeah.
And nerve conduction studies, NCS, measure how well signals travel along the nerves. These tests help pinpoint the level of the injury, roots, trunk, cords, and assess the severity. Can any signal get through? Are there signs of nerve death, known as denervation?
But you can't do these tests immediately.
No, and that's a crucial point. Performing EMG NCS too early after the injury is unreliable. You need to wait for the process of Wallerian degeneration, the breakdown of the nerve axon distal to the injury site, to fully manifest electrically. The general consensus is to wait at least 3 weeks after the injury before performing the first definitive electrodiagnostic assessment. Doing it sooner can lead to false negatives or ambiguous results, which isn't helpful for making major decisions.
That 3-week or potentially longer waiting period must be incredibly difficult for everyone involved, especially the patient.
It is. It's a period of significant uncertainty, but it's necessary to get the most accurate information possible.
So, assuming the tests are done and they confirm the worst, a complete brachial plexus avulsion, the Zell type 4 picture, what happens then? When does the conversation turn towards amputation?
Once a complete irreparable brachial plexus avulsion is confirmed, both clinically and electrophysiologically, the multidisciplinary team needs to have a very serious discussion with the patient about the path forward. In this situation, where the limb is definitively proven to be permanently paralyzed, insensate, and functionless, essentially a flail extremity with no prospect of recovery, then early amputation often becomes the recommended course of action. This might be an above-elbow amputation or sometimes even a 4/4 amputation, depending on the specifics.
Why the emphasis on early amputation historically wasn't the approach sometimes to wait and see for maybe 6 or 12 months, just in case?
That wait-and-see approach has largely fallen out of favor for confirmed complete avulsions, for several good reasons. Firstly, from a purely physiological standpoint, especially if there was significant crush injury involved initially, removing the non-viable tissue early can reduce the long-term risks of chronic infection, breakdown, and potentially even late systemic issues. Secondly, and perhaps more importantly, is the impact on psychological well-being and overall functional rehabilitation. Living with a flail limb, as we discussed, is incredibly burdensome. It's often painful, it gets in the way, it requires constant care and attention, and it's a constant reminder of the injury. Holding on to it for months or years and the futile hope of recovery that the evidence says won't come can significantly delay psychological adjustment and adaptation. There's growing evidence suggesting that patients who undergo earlier amputation for a confirmed non-salvageable flail limb get fitted with a functional prosthesis, if appropriate, can actually achieve a better quality of life, adapt quicker, and potentially return to work or meaningful activity sooner than those who retain the functionless limb long-term.
So it's about removing a liability to allow the patient to move forward.
In essence, yes. The goal shifts from limb salvage at all costs to maximizing the patient's overall function and quality of life. Sometimes removing the biological limb is the best way to achieve that, allowing replacement with a potentially more useful, though still limited, prosthetic, or simply freeing the patient from the burden of the flail limb.
It's still a huge decision, though. Amputation carries its own significant burdens: psychological trauma, anxiety, depression, phantom limb pain. That can't be underestimated, even if the biological limb wasn't functional. How do clinicians navigate that incredibly difficult conversation?
It has to be a process of shared decision-making, absolutely. It requires empathy, clear communication, and a truly multidisciplinary approach. The team, orthopedic surgeon, vascular surgeon, if involved, plastic surgeon, sometimes involved in closure or later reconstruction, specialist nerve surgeons, physiotherapists, occupational therapists, pain specialists, and crucially, clinical psychologists or psychiatrists and social workers needs to be involved. The surgical team's role is to present the objective medical reality as clearly and compassionately as possible, based on the Zell classification and the electrodiagnostic findings. The evidence tells us this limb will not regain function. Keeping it means living with the challenges we've discussed. Amputation offers a different path, with its own challenges, but potentially leading to better overall function and less burden.
So managing expectations is key.
Managing expectations is paramount. Patients and families need to understand that limb salvage in this context doesn't mean saving a working limb, it means retaining a non-functional appendage. Amputation means removing that appendage to potentially enable better adaptation and prosthetic use. It's never an easy discussion, and the patient's values, goals, and psychological state must be central. But when the neurological prognosis is truly zero, guiding the patient towards amputation, while difficult, is often considered the most responsible and ultimately humane course for their long-term welfare.
It certainly highlights that the orthopedic role in STD extends far beyond just fixing bones.
It absolutely does. It requires prognostic understanding, multidisciplinary teamwork, and difficult ethical considerations. The technical skill of the ORFF is important, but it's only one piece of a much larger, more complex puzzle. Focus on the patient's whole future. #outro.
Professor, this has been an incredibly insightful discussion into a really challenging injury. As we bring this deep dive to a close, what would you say is the single most important takeaway message for our colleagues managing trauma?
I think the unifying lesson is about predictive primacy. While the orthopedic fixation needs to be technically excellent and robust, you have to stabilize the clavicle, the SCJ, the CC ligaments, essentially compensating for those lost muscles. You must always remember that the neurology dictates the prognosis. Your primary focus, once the patient is stable, must be on accurately assessing the completeness and the level of the brachial plexus injury. Is it a Zell type 4 complete avulsion? That neurological status is, by far, the most critical factor determining the patient's long-term function and quality of life. It outweighs the initial degree of scapular displacement on X-ray. It outweighs whether the vascular repair was successful. Understanding the nerve injury guides everything that follows, from surgical planning to those difficult conversations about amputation.
A clear focus on the nerves as the ultimate determinant. If you've found this deep dive valuable today, please do take a moment to rate and share the show with your orthopedic colleagues. It really helps us continue bringing you these detailed clinical explorations.
And perhaps a final thought to leave people with. This discussion really highlights how, for such a devastating injury, we still lack universally agreed, detailed treatment algorithms, particularly for navigating that amputation decision in the face of confirmed type 4 injury. Given that we know the Zell type 4 neurological status is paramount, maybe future research and guideline development shouldn't just focus on refining surgical techniques or using broad scores like the MSS score, which often doesn't capture the specific neurological reality of STD. Perhaps we need to develop more dedicated interdisciplinary decision-making frameworks that explicitly integrate the profound psychosocial and long-term functional impact of living with a flail limb versus undergoing amputation, helping us support patients and surgeons through that incredibly difficult choice.